Awesome. So now we're recording and we can go ahead and get started. So as you know, this exam is on anti-infectives, inflammation, infection, immunity, and those hypersensitivity reactions. And we will start with just some reminders. Your professors asked me to share some study tips, just or general reminders for us. We are about 5 days out from your exam, so this is a great time to begin studying if you haven't yet. Studying in increments is super efficient instead of cramming all the night before. But at the end of the day, you know what works best for you. As always, work with your professor. They are here to help. And for patho specifically, your professors throw in practice questions in the slides that are great resources to use. Writing things down, as you know, will help retain better than typing. If writing concepts doesn't help you, verbally teaching them, even to an invisible audience, can help. I sometimes look like an idiot, but I'll walk around my apartment just teaching to nobody, and it helps me remember things. Always studying involving active recall will be beneficial, and then get that good sleep that I talked about last time. All right, so we're going to start with pathophysiology of infections. Here is a list of general terms to know. Again, like last time, I'm not going to go through these one by one, but I recommend making flashcards or Quizlets with these terms just to familiarize yourself and be able to understand them used in questions. Alrighty, so normal flora, we all took microbiology, so you might remember this from then. It's the microbiome that exists on our body at all times. People typically associate bacteria with being bad, but all of us have bacteria on our bodies and in our bodies, and that's just our normal flora, our microbiome. And when you take antibiotics, you also kill elements or all of the normal flora that your body needs. And that causes opportunistic infections like C. diff or yeast infections. But we're going to talk more in details about those up here. Antibiotic resistance, again, if you took microbiome, especially with Jeff Helms, you know all about antibiotic resistance. This is most commonly caused by people not taking the entirety of a prescription, not taking them as prescribed, sharing antibiotics between friends or family, simply taking the wrong antibiotic, which is not the fault of the patient. That's typically the fault of the provider. And then microbial adaptation too. These microbes and bacteria are constantly.
Dạ,
Um,
dạ để đó đi.
if your mic is on,
Để
could you just
chút nữa
turn
khi
that
nào.
off for me? Okay, thank you very much. Um, so for our role as nurses, how to reduce antibiotic resistance, you teach always with antibiotics that your patient needs to take the entire prescription of antibiotics even when they feel better. That is key to halting antibiotic resistance, and then not sharing antibiotics. That's also just a way to stop that resistance from developing. Alrighty, the different kinds of infection types. First is community acquired. These are most infections that like you and I would get. This is, strep throat from school or I don't know, just any kind of infection, maybe pink eye that you just get and you might go to urgent care and get it treated. So these start outside of the healthcare setting altogether. Healthcare associated is caused from healthcare in any setting. So this is different than hospital acquired because healthcare could be a clinic, it could be a pharmacy, just picking it up from a location involving healthcare. So maybe you just go to your primary care for a well visit and you come across a pathogen and you get sick with the flu or a cold or whatever it might be. Hospital acquired then is specifically within a hospital. And the example that's the most common is going to be with catheters. People get UTIs from catheters in the hospital all the time, unfortunately. Those are CAUTIs, catheter acquired UTIs. So yes, hospital acquired are from the hospital. These also happen post-op with incisional infections. Opportunistic infections, that's what I was talking about with the C. diff and the yeast infections. This is when the normal flora in our body becomes pathogenic, which happens in cases of antibiotic use, decreased immunity, burns, or within cancer patients. And then superinfection as well is that development of a second infection related to antibiotic use because you're suppressing your normal flora. So again, C. diff and it's candidiasis, which is yeast infections. I would definitely know those two and how they're opportunistic superinfections from antibiotic treatment. Infection transmission, I'm not going to go super into detail on this. Portal of entry is how the pathogen enters the body. And that's when we kind of talk about those droplet airborne contact precautions. Those are just the different ways that a virus is transmitted or an infection. And then infections are transmitted by humans, animals, fomites, which are those inanimate objects like a desk or a doorknob, vehicles, and vectors. Vectors are like the insects, like mosquitoes or ticks would be examples of vectors. For defense mechanisms, our first line um, is going to consist of things like your skin and your mucus. These are protecting your body without kind of like that conscious effort of doing so. Um, as well as secretions. I always thought tears were super important. Like when you cry, your tears are super acidic. So if there's any bacteria, that will just kind of naturally kill that off. As well with GI acid. If you eat something that has bacteria in it, there's a good chance that your GI acid, your hydrochloric acid, will go ahead and kill that as a first line defense mechanism. And then also movement. Coughing is a great example. If you have a pathogen in your lungs, coughing is a way for your body to just get it out. So then if something breaches your first line defense mechanism, that is when your second line defense and tertiary defense comes in as well, which is that phagocytosis or the engulfment of pathogens and invaders, and your general immune and inflammatory response, which we learned about the inflammatory response last time, and shortly here we'll go into more about the immune response. Clinical manifestations of infection are super, super similar to that local and systemic signs of inflammation that we talked about last time. So for local infections, you're going to see kind of those cardinal signs of inflammation. We have the redness, the swelling, pain, warmth, and then also loss of function. Um, these are just like typical, maybe you have a cut on your hand and it gets infected. These are the signs and symptoms you're going to see. And then a systemic infection, again, super similar to systemic inflammation. This is when you're going to see the fever, tachycardia, tachypnea, fatigue, malaise, weakness, nausea, vomiting, headache, all those types of general symptoms. So you might see those with something like you have strep throat set in, or even something like sepsis or bacteremia, an entire body infection. The stages of infection are important to know. So they start with incubation. This is when the pathogen is actively replicating in your body. And incubation is defined as the time between exposure to the very first onset of symptoms. When you get sick, you actually acquired the pathogen or virus sometimes hours to days to weeks before you actually start showing symptoms. So that would be the incubation period. And then you have prodromal. This is identified by that first appearance of symptoms, but you're not kind of like down yet. Typically, we all know when we start getting sick, maybe you have a sniffle, a headache, whatever it is, that's prodromal. Then you go into the full or acute stage of infection when it's at your peak. This is at its peak. This is when you might be staying home from class, you just feel so sick, nothing is helping, you can't sleep, whatever it is. This is the worst your infection will be. So this is when the pathogen is just growing and multiplying rapidly. And you'll see your worst symptoms during this time period. And then the convalescent stage is when the infection is on the downfall. We all also know this feeling. It's incredible. You wake up for the first time in like a week and you're finally feeling better. That's awesome. So this is when your body begins to repair itself. You're returning to normal function. But symptoms like fatigue or just general malaise may persist for a little bit longer, especially with something like your COVID infection or flu. Those types of things can sit with you for a while. Labs, cultures and sensitivities are super important. These also determine how we use anti-infective treatment. So culture is a lab test that identifies the type of bacteria. Um, and then the sensitivity is what identifies how effective a certain antibiotic would be on that bacteria. So it's really, really hard to prescribe an effective antibiotic without obtaining a culture and sensitivity. So in general, you have to obtain, or you should always obtain, a culture and sensitivity before the administration of any antibiotics, because otherwise you're kind of just shooting in the dark and hoping that the antibiotic that was prescribed will work. And then another major marker for infection is going to be that white blood cell count. Your normal range is 5,000 to 10,000. Increased above that is indicative of infection. So that's leukocytosis is the technical term for that, is more white blood cells or more than 10,000. Okay, so here's our first practice question. You are welcome to unmute yourself and verbally share the answer or type it in the chat. People typically prefer to just type it in the chat. And once I start seeing answers come through, we'll move forward. So the more involved you are, the more helpful all of this is. Yay. Okay. Awesome. Yes, I'm seeing lots of A's. You guys are correct. So that's A. Typically, it's not always the case, especially in urgent care settings. You go in, they say you have an ear infection, they just give you an antibiotic. But especially in the hospital, you should always obtain that CNS before the administration of antibiotics. So good job. Which of the following, oh, I can't even see it, is not a first line defense mechanism in the immune system? Awesome. Yes, you guys are saying C. Perfect. That's going to be the secondary and tertiary defense mechanisms. But the other three, mucus, tears, and the peristaltic movement of your gastrointestinal system are all primary first line defense mechanisms. Okay, so this brings us to our biggest chunk of material for this exam. It's going to be the antibiotics. And these can be super anxiety provoking just because there are so many of them, and there are a lot of similarities. But I say use that to your advantage. The fact that there are so many similarities, study them as a group and then just focus on what makes each one different. That's going to be the most effective way to study the antibiotics, just going through. As well as in general, when you learn about a certain drug class, study the class and then what makes each medication different. That'll just be a major headache reliever for you guys, I promise. Alrighty, so again, that general information. These are, let me close out of this. I'm sorry, I can't even see my own slides. Okay. These are anti-infectives are used for bacterial infections and the prevention of bacterial infections. In general, antibiotics have a high chance of hypersensitivities and kind of reactions occurring. And they also can cause respiratory distress, that angioedema that we'll talk about later with hypersensitivity, superinfections, and those opportunistic infections, as well as GI symptoms. For nursing interventions, you want to always check for allergies. That'll be a super big component of antibiotics. And then you have to teach to take all of that medication until they feel better. So we're starting with penicillins. The prototype for penicillins is ampicillin. With almost every single antibiotic, the major adverse effect is hypersensitivity. And especially with penicillins, there is a higher risk of allergies. True allergies or not, people are going to say that they're allergic to penicillin. Um, Black box warning for penicillins is if you administer penicillin that was meant to be intramuscular through an IV route, the patient is at risk for cardiopulmonary arrest and death as a result. So that's a pretty serious one, but that's kind of like an accidental, if you do this, then this will happen. Contraindications with penicillins, there's a cross allergy, cross sensitivity to all cephalosporins, and vice versa. So if someone says they're allergic to a cephalosporin, you cannot give them ampicillin, penicillin, any of the penicillins, because there is a cross sensitivity that is super important to know. So for those nursing interventions, you always ask about an allergy. And if they start experiencing any signs and symptoms of an adverse reaction, you want to stop that infusion right away. Um, and then also with penicillin being such a high chance for allergies, it is important to know the antibiotics that are good alternatives to penicillins and therefore cephalosporins. And the acronym that I used was TEACH. This was like the best thing I could come up with when I took this class. So there's tetracycline, erythromycin, azithromycin, clindamycin, and then clarithromycin. That's where the H comes from. Otherwise, just do TEACC, and you might be able to remember it that way. But that helped me so much when I was studying for this as well. The next one is the cephalosporins, which does have that cross sensitivity. The prototype is cefazolin, and this antibiotic is primarily used for surgical prophylaxis. So 1 hour before surgery, it's typically given, and that'll help prevent infections acquired through surgery. Um, and again, really the main contraindication is that cross sensitivity to penicillin. Um, and then as well, if your patient reports diarrhea, you want to stop and report to the provider because of the increased risk of C. diff with antibiotics in general, but also cephalosporins. And then, like many IV medications, it's going to be administered slowly to prevent irritation of the veins. Then you have your aminoglycosides. This is gentamicin. The important thing to remember about gentamicin is that it has a very narrow therapeutic range. So you have to do serum drug levels to make sure that your drug level is within that expected range. Otherwise, you see those black box warnings, your patients at a higher risk for those. So those are nephrotoxicity, ototoxicity, and neurotoxicity. Gentamicin is great as long as it stays within that therapeutic window. And then streptomycin is another aminoglycoside that can cause paresthesia or numbness/tingling of the extremities. Then you have a fluoroquinolone. This is Cipro or ciprofloxacin. Like all antibiotics, an adverse effect is GI symptoms, so nausea, vomiting, just general stomach upset. And the black box warning is kind of unique. That's going to be the rupture of your Achilles tendon. So if your patient, you're going to teach them that you want to report any signs of discomfort in the Achilles heel region. And then also because of that risk, it is not safe for use in patients under the age of 18. Okay, so here's another question for us. Which of the following medicine is the first line antibiotic for surgical prophylaxis? Yeah, you guys are all saying C, and you are correct. C is going to be that surgical prophylaxis given 1 hour before a surgical incision is made. Which of the following medications is not safe to give to someone with a with cephalosporin allergy? Oops. Yeah, you guys all got that. I also said it, but yeah, you got that, and that's important to know. Which of the following antibiotics has a black box warning for rupture of the Achilles tendon? Yep, you guys all got that one as well. That's going to be your Cipro. Okay, so moving on to our next one is tetracycline. This is that T and teach for options with PCN allergies. Adverse effects again is that hypersensitivity, and then there's also a risk for renal and liver toxicity. And the unique one with tetracycline is delayed growth in children, as well as teeth discoloration and enamel hypoplasia if under 8 years of age. So if a patient is under 8 years of age, doxycycline is the only tetracycline that is safe and available to take. So I would just kind of remember tetracycline's impact on growth and teeth in children and why that's important. Um, and then nursing intervention to know is that you should not take a tetracycline with dairy, antacids, or iron. So you're going to want to space all of those out. Then you have your sulfonamides. These are your prototype is trimethoprim sulfamethoxazole. Sorry, it's a mouthful. This one also has an adverse effect of hypersensitivities and then photosensitivity and rash. So that's an issue kind of with your skin responding to light. Contraindications are renal failure, pregnancy, and in children. And this one is a different allergy. You cannot take a sulfonamide if you have a sulfur allergy. And because of that, there is a cross sensitivity with thiazide and furosemide and sulfonylureas, which is a diabetic medication that you'll learn later. So yes, sulfur allergies, you can't be prescribed a sulfonamide. Macrolide is erythromycin. This is another option for PCN allergies. Azithromycin and clarithromycin are also macrolides, but erythromycin is the prototype that you should know. But the benefits of those newer macrolides are that they work better and they have fewer adverse effects. Um, and then your adverse effects are liver toxicity, colitis, and hypersensitivity again. Clindamycin, again, is another option if a patient is allergic to penicillin. The black box warning is for colitis, so that's infection or irritation of the colon. And it's often used in combination or alongside aminoglycosides and fluoroquinolones. And then I think we have two more. So then there's metronidazole. This is used to treat primarily C. diff infections. Um, and the adverse effect that's kind of unique is the metallic taste. Your patients may complain of that, but it is normal. Typically, something like spearmint gum or mints will help get rid of that taste or at least make it more bearable. The black box warning for metronidazole is an increased risk for cancer. And you are also not supposed to drink alcohol while on metronidazole, so that's an important thing to go ahead and teach. Also, we've talked about C. diff a lot, but I haven't really explained it. Um, but I'm sure we've all either experienced it, worked with it in one way or another, or have at least learned about it. C. diff is a pretty intense, opportunistic superinfection of your GI tract, and it causes very intense diarrhea, that has a very unique smell to it, and it's super watery. Um, so C. diff is not a fun thing. And that's why, in general, if any of your patients on antibiotics start having that watery, excessive diarrhea, you want to think about C. diff and initiating those contact precautions because it is highly contagious as well. So, yes. definitely know about C. diff. And if you haven't worked with that yet, you will. Guaranteed you will at some point. That's metronidazole. The last one that we talk about for antibiotics is vancomycin. This is primarily used for serious gram-positive infections like MRSA, because then you get that's methicillin resistant. So then you move to vancomycin. The adverse effects are kidney toxicity, ototoxicity, and then the primary one is that vancomycin infusion reaction. This used to be called Red Man syndrome, and it was changed due to cultural sensitivity reasons only relatively recently. So that is vancomycin infusion reaction. It begins after the infusion starts and is typically related to the fast rate of infusing vancomycin. Before anything else, you need to stop that infusion and then you can notify the healthcare provider. It's super easy to freak out and just leave the room to go get a provider, but your first action has to be to stop that infusion if they're reacting to it. Another unique thing about it is patients who have an allergy to corn cannot take vancomycin. So you have to test for a corn allergy, which is relatively bizarre as far as allergies in medicine go. But definitely ask about a corn allergy. That puts them at a risk for reaction. And then because of that risk for the vancomycin infusion reaction, you have to give it very slowly. And just like gentamicin, you have to monitor those levels and do like the drug serum levels relatively frequently if a patient's on vancomycin. Okay, so now we have some more practice questions on the rest of the antibiotics. So which medication should children avoid related to dental concerns? Awesome. Yeah, you guys are all saying C. You are correct. Again, if it's a child, the only tetracycline that's safe is going to be the doxycycline, but you are correct there. What should you do first if a patient starts experiencing a vancomycin infusion reaction? Yes, you guys all got that super fast. Good job. I'm going to go back actually because the other three things are obviously super important to do, but you want to look at that priority is always going to be to stop it, and then you can move forward and do those other things. Which antibiotic requires the nurse to check for a sulfa allergy prior to administration? Yes, you guys are all correct. The answer for this one is B, and the prefix of the name does give it away with that sulfa methoxazole. Which antibiotic is used to treat C. diff? Clostridium difficile. All of its glory. Okay, I'm seeing a few different answers here for this one. The correct answer is A, metronidazole. This is the one primarily used to treat C. diff infections. What is the black box warning for clindamycin? Okay, yeah, you guys are all correct. This one is colitis. I threw a cancer risk as like a trick in there. That is the black box warning for metronidazole. The other two aren't explicit black box warnings for any of these antibiotics. Okay, so those were all the antibiotics. Like I said, I know that's a little bit overwhelming. I do have more practice questions that I'm going to give as a practice test to your instructors. So hopefully that at least helps prioritize the key information about each antibiotic for you guys. So next is immunity. And immunity is one of those things where, at least for me, no matter how many times I study it, I get confused every time, especially with, humoral versus cell-mediated. And at this point, this is probably your third or fourth time learning about it in college, from micro to anatomy and everything. So I just recommend, if these resources aren't working for you, look back at your anatomy or micro knowledge and see how you can apply that to this class to help you with this exam. Um, so again, here are some terms to know. Again, flashcards are great for just terms like these ones. Alrighty, so first is innate versus adaptive immunity. Innate immunity is that early and rapid response. It's natural and it's non-specific. So when your body has an invader of any type, your body responds with innate immunity. So this immunity process consists of your physical or chemical barriers, which is what we talked about with skin, mucus, the GI secretions, the acid in your tears. That's part of innate. white blood cells, complement proteins, dendritic cells, natural killer cells, and cytokines. Those are all components of the innate immune system, and they just respond to a invader. Point blank, it doesn't matter what it is. Those just work to protect your body from any kind of pathogen. Whereas adaptive immunity develops later and it acts slower. It develops after birth. So you are not born with adaptive immunity like you're born with innate immunity. And this one defends against specific antigens. So this type of immunity develops either actively or passively, which we'll talk about more in detail a little bit later. But adaptive immunity consists of humoral or cellular immunity, which we're also about to talk about. So just the key differences there are in bold, just kind of remembering that innate is generalized, it's fast, and it's natural, whereas adaptive is acquired and it each kind of mechanism is for a specific antigen or pathogen. So humoral versus cellular immunity, these are both components of that adaptive acquired immunity. Humoral involves B cells or B lymphocytes from the bone marrow. So B from bone, B and B. That helped me remember it as well. And then B cells or B lymphocytes are what produce your antibodies, then mark specific antigens for instruction. So that's the function of the B cell in acquired immunity or adaptive immunity. And then cellular immunity is involving T cells from the thymus. So again, great alliteration, T and thymus to help you remember that. And this defends against infected cells. So I like to think of like cells that have already been infected versus just kind of like an antigen in your body. So cellular immunity involves helper T cells, those CD4 cells that produce cytokines, the cytotoxic T cells or CD8 that work to kill cells by altering the cell membrane, suppressor T cells that work to suppress B cells as needed, and then memory T cells that work to recognize antigens from prior exposures. And what I did for these two is I feel like I might not be able to explain them in the most effective way. So I did some research and I pulled some videos that might be more beneficial for you guys if this concept is confusing at all. So when I share out this slideshow, you're welcome to take a look at these. And like I said, I do recommend using, if you still have them, resources from anatomy or microbiology to help with this material. And then you have, oops, there you go. And then you have active versus passive immunity. Active immunity is immunity that's formed from exposure or immunization. A lot of people might think immunization is passive, but that is an active form of immunity. Um, so the two ways that that happens is encountering it naturally. That's you got sick from a friend or your boyfriend, girlfriend had something and you got it from them. That's active immunity. And then vaccines as well. So nursing requires our flu shots by next week. So I just got my flu shot. So that's an example of active immunity. And then passive immunity is transferred immunity. So the receiving of antibodies or immunity. Whereas, like I said, active, you're making those antibodies. So the two examples that you need to know for passive immunity are going to be IgG from the mom to the baby, which we're about to talk about more as well. But that goes through the placenta. And then also gamma globulin injections. These aren't done super, super frequently, but you might have heard them talked about a little bit with COVID. But that's another example of passive immunity because you're directly giving an antibody or immunoglobulin to the patient to help fight the infection. So these are the immunoglobulins. My like acronym or mnemonic for them is GAMED. That was just the order that helped me remember them. So IgG is the most abundant immunoglobulin and it does cross the placenta. So that's how fetuses receive passive immunity from their mother, is through the placenta and IgG. And then IgA is the next most common immunoglobulin. This one specifically prevents attachment of the pathogen to epithelium and epithelial cells. And this one can transfer to a newborn through breast milk. So that's another, you'll learn more in maternal infant, but that's a benefit of breastfeeding is that you do get those IgA antibodies transferred. Um, IgM exists within the intravascular space. It is the very first one made by the fetus during fetal development. And then IgE is bound to mast cells and it causes a histamine or allergic response. So we will talk more about those as well. Those are highly involved in allergies. And then IgD bounds to and activates B cells, which, as we talked about, are what create the antibodies for humoral immunity. Autoimmune disorders are caused by the body not being able to identify self from non-self. So your immune response is directed at healthy own cells that don't need to be destroyed. So that's the general gist of autoimmune disorders. Okay, here's another question. Which immunoglobulin activates B cells? Yeah, you guys are all right. That one's going to be E. That is the main function of IgD. Which is the first immunoglobulin made during fetal development? Okay, I'm seeing a few different answers here again. So C for this one is the correct answer. C is the first one that the fetus makes, which is important to know. Whereas IgG, I do see the confusion. IgG is transferred from the placenta to the baby, but the baby doesn't make IgG. They receive it from their mother. But IgM is formed by the fetus. So I hope that clarifies that a little bit more. Okay, so those were the questions for immunoglobulins. Then we're moving on to hypersensitivities and allergies. With allergies, these are kind of two important symptoms slash signs to know for clinical manifestations. Angioedema is the fluid buildup in subcutaneous tissues that creates edema. And this is super important and can be life-threatening because it can happen anywhere, even in the airway. So when someone's throat starts to close during an anaphylactic or allergic response, that's that angioedema limiting their airflow. And then also urticaria is pruritic, which just means itchy, pink or red papules that progress into wheals. So those are two super common clinical manifestations of an allergic response. The types of hypersensitivity responses, this is unfortunately just kind of something you have to memorize. Type 1 is common allergies to food, animal pollen, etc. Lots and lots of people have a type 1 hypersensitivity to something. And that involves that IgE that I mentioned. That plays a major role in the release of histamine and chemical mediators in allergies. So if someone's allergic to peanuts or dander or dogs or cats, or I'm allergic to bug spray, like those are all type 1 hypersensitivity responses. Type 2 involves the immunoglobulins G and M, and these are often examples of these are autoimmune disorders and blood transfusion reactions. And then type 3 also involves IgM and IgG and M and can also involve react or autoimmune disorders, but another characteristic is a drug reaction. Um, and then lastly, type 4 is a delayed hypersensitivity response that involves the T cells instead of an immunoglobulin. And a good example there is the TB test. If you've all had to do a skin TB for nursing, that's an example of type 4. And then also something like poison ivy when you get those welts, itchy welts from it, and then also alloimmunity. So the signs and symptoms of an allergic reaction and anaphylaxis. Um, so there are kind of different levels of allergic reactions that progress to anaphylaxis. And these can worsen from seconds after being exposed to the allergen to minutes to hours. It just kind of depends on the severity of the allergy. You can have a mild reaction. This could involve tingling in your body, warmth, a sensation of fullness kind of in your chest or your stomach, and then congestion. So that's a mild allergic reaction. And then a moderate allergic reaction has the same kinds of symptoms, but then add in flushing, anxiety, bronchospasm. So your bronchi are kind of spasming, making it a little harder to breathe. Dyspnea, which is that shortness of breath, a cough, and wheezing. So typically, this is when someone would start to seek medical help. With a mild reaction, they might not feel like they need to, but once they start experiencing the bronchospasms and the shortness of breath, that's when it starts to get scarier for the patient, which causes anxiety, which causes worse breathing and wheezing, and it's just kind of a cycle that goes on from there. And then severe allergic reaction is going to involve all of those symptoms that we just talked about for mild and moderate. But you add cyanosis, hypotension, dysphagia, you can have nausea, vomiting, or diarrhea, you can have seizures, and then this is also when someone can die either from anaphylactic shock or maybe a closed airway or bronchospasms, etc. With allergies, your priority assessment is always going to be the airway. Um, Always think ABC, and this is not just for this test. That will come again and again and again. But especially for allergies, assessing that airway is incredibly important, just in that emergent situation. And anaphylaxis, as we said, can cause death related to shock. So you really want to monitor those vitals. So if their blood pressure starts dropping and their heart rate starts skyrocketing, that is not a good sign as far as risk for shock goes. So you'd want to notify the provider of hypotension or tachycardia. So here's another question for us. What immunoglobulin does a type 1 allergy response involve? Yeah, you guys are all correct. That is D, IgE. Good job. Alrighty, what is urticaria? Awesome. You guys are all correct again. That is going to be A. And then I put a note in there that B is angioedema. C is hematuria. That's kind of not an important thing with um, allergies. And then systemic inflammation just isn't applicable to the question. Alrighty, so then we just have a few more medications to cover. We're going to cover epinephrine, diphenhydramine, cetirizine, and prednisone. Alrighty, so epinephrine, we've all probably heard of this medication or heard of EpiPens. This is used in severe allergic reactions to cause immediate bronchodilation, and it also inhibits chemical mediators like histamine. This is what people carry around with them if they have something like a peanut allergy, because they can self-administer specifically in their thigh and get that bronchodilation before they um, lose the ability to breathe. And that gives them time to get to the hospital. Adverse effects are hypertension and tachycardia, but in these events, the benefit should and will outweigh the risk of those adverse effects. It is a high alert med when given in the hospital, so keep that in mind. And then, like I said, there is that auto injector form for it. There's something else I wanted to say about Epi. Oh, yes. So if someone begins having a severe allergic reaction to something like peanuts, it's the easiest example to give, and they give themselves Epi and they feel better, they still need to go to the hospital because the thing with Epi is it works fast and it can also wear off fast. And someone might require multiple doses of Epi and further treatment for a severe allergic reaction. So Epi is just kind of I don't know, like a time buyer, like you're buying yourself some time before you can get more help. So seek medical help even if a patient has received epi. Next is diphenhydramine. This is Benadryl, as most of us would know it as. This is a first generation antihistamine, which means that it has more adverse effects than the second gen that we're going to talk about. Um, this antagonizes the action of histamine, so it'll work against that histamine, which creates a lot of those responses in allergies. It's non-selective, which is a characteristic of it being a first generation medicine, and it has a sedative effect. So it's primarily used for rhinitis, that angioedema, but then the unique thing about it too is that it can be used preventatively for transfusion reactions and contrast dyes. So they'll give it to patients via IV before a blood transfusion or like a CT with contrast to prevent any potential reactions that could occur there. And the adverse effect is sedation. If you've taken Benadryl, you know it's like after 30 minutes hit, you kind of feel like you just need to go sleep. You might even have brain fog. So because of that, we typically tell patients, hey, don't drive, don't operate machinery, those types of things after taking Benadryl because it will sedate you, and that's related to its second gen nature being that non-selective sedative inherently. Then the second generation antihistamine is going to be cetirizine. This is Zyrtec. This is a lifesaver for so many people, especially people with seasonal allergies. This selectively binds and does not cross the blood-brain barrier. So there's a less chance of sedation or drowsiness, meaning that it's safer for children and older adults to take. This is also just used for allergies, seasonal allergies, rhinitis, etc. But the primary reason too that it's safer for older adults is that it doesn't increase their fall risk. Diphenhydramine or Benadryl, because it has that sedative effect, will create an increased fall risk for your older adult patients, but cetirizine without a sedative effect won't do that. So that's why it's safer for older adults. The last medication has a lot of information. I think I have 3 slides on it, and I still like condensed it as much as possible. So prednisone. Prednisone is a corticosteroid, and typically, just moving forward in nursing school, if a medication ends in ONE and has that own to it, it's going to be a corticosteroid. So that's just a little tip to help you when you're going through classes and exams. Um, but these are widely used to decrease inflammation and the immune response. The important thing to know is that it's not curative. If someone has chronic inflammation, they can't take prednisone and just magically be better. It might help them feel better for a little bit, but it's not going to fix their problem. Um, because prednisone does have a lot of adverse effects, you want to give the smallest dose for the shortest amount of time. That's kind of the ideal goal because that's the list of some of the adverse effects. But there's Cushing syndrome, hyperglycemia or high blood sugar, sodium and water retention, calcium loss, and then because it decreases your immune response, you're at an increased risk for infection. And because it decreases your inflammation response, you are therefore at a risk for slower healing. So just kind of using logic to think through that. If you know a steroid decreases your immune response, you're automatically more susceptible to infection. So just kind of putting those pieces together when thinking about nursing interventions will be super helpful moving forward as well. Prednisone is sometimes given alternate, what we call alternate daily therapy or ADT. This is used for people who are on prednisone long term. And this is when you double the dose every other day so that you have less adverse effects in general. At first, it confused me because I thought doubling it would mean that you have more, but it's that alternate daily therapy. So your body kind of manages a more, I was going to say a more level, but that doesn't really make sense, a more steady level of the prednisone. In general, you want to monitor wound healing, the clinical manifestations of infection, as well as blood glucose, and that's all related to impaired inflammation, infection, and blood sugar control. Um, and then, so sorry, especially if your patient's a diabetic, it can make their blood sugar a lot harder to manage. With prednisone, you want to taper down the dose to prevent abrupt adrenal insufficiency. So you should never stop that abruptly. If you guys have ever taken a steroid or a prednisone, or sometimes they're called a dose pack, they kind of look like a triangle. The first day you take 6, and the next day you take 5, and then 4, and it just automatically tapers down. That is the safe way to stop prednisone, because of that risk for adrenal insufficiency. So you want to teach, generally you should take prednisone after meals. It also kind of has a foul taste to it. So if people need like a juice or something to take it with, definitely give them that as long as they're not in PO. You want to teach them to practice hand washing and avoid those who are sick if at all possible. Just those general precautions to limit the risk for infection. And then things you want to be aware of is weight gain of more than 5 pounds in a week, shortness of breath, or vomiting. These are all issues that could come from prednisone, and those are worthy of notifying your provider. Another thing, if a patient is experiencing increased stress, you want to well, your provider should increase the dose of the steroid or prednisone that's needed. For it to actually be effective, it's gonna have to be increased. So think of someone who's on long-term use of prednisone and they come into the hospital for an illness, an acute illness. For the prednisone to actually be effective, you have to increase it to match that stress level. And then you can taper it back down to a more maintenance level dose, but it has to kind of correspond with levels of stress. And for our sake, think of stress as surgery, hospitalization, etc. Um, and like I said, long-term use of prednisone is a thing, and that's oftentimes in cases of Addison's, which is a disease that causes adrenal insufficiency. So prednisone being a corticosteroid will mimic the actions of the adrenal gland instead. Okay. When does a patient need to contact the provider when taking prednisone? Select all that apply. This one might be a little bit tricky. I don't know. Let's see what we're saying. Okay, awesome. I'm seeing a lot of good answers here. Um, I'm gonna go through each one just because I'm seeing a little bit of varying answers, but you guys got the right idea. Um, okay, yes. So weight gain of 2 pounds was not significant. Loss is also not significant in this case. Um, Weight gain of 5 pounds per week is gonna be that level that you should contact your provider. Shortness of breath, just we're talking anytime something impairs airway or breathing, that's an issue to discuss. Edema and then vomiting as well are going to be ones you want to contact your provider about. Slow healing is an expected effect from prednisone, so it's not, you don't need to contact your provider. You should be experiencing slow healing if you're on prednisone. So that's why that's not something you would contact your provider for. Okay, true or false? Cetirizine is selective and therefore has a lower risk of drowsiness. Yeah, you guys all got that one. That one is A. That is true. Diphenhydramine is going to be the non-selective one that has a higher risk of drowsiness. Okay, true or false? Diphenhydramine is used as a preventative for transfusion reactions. Okay, I'm seeing different answers on this one. This one is going to be true. It has other uses. This isn't the only use for it, so I like if that's where you're coming from, totally understand that. But it is used in this case as a prevention for transfusion. That's another use for it in response or in addition to seasonal allergies or rhinitis and those types of things. Okay, so that is all I have for you guys today. Like I said, I do have a practice test to give you. I am going to have your professors, or I'll email that out to you after this, and you can do it on your own so you can work through it that way. If you guys have any questions, feel free to throw them in the chat, unmute yourself, or just shoot me a quick email. I am here to help in whatever way I can. So yeah, I hope that you guys are we going to get the PowerPoints emailed to us? Yes, if you threw your email in this chat, I'm going to email it to you after we get off tonight. But otherwise, your professors will post the recording. Um, I'm sorry, the recording, the slideshow, and the practice test as well. Yes, of course. So if you are just now seeing that, let's throw up attendance again. Go ahead and put your email in the chat so I can get it to you all tonight. And if you didn't fill it out, please go ahead and fill out this. Okay, I just stopped sharing, so that's on me. Does anybody else need